The time for the meeting has arrived. We'll go ahead and begin our subcommittee meeting. Chairman Ben Harbin recently appointed a special appropriations subcommittee on Department of Human Resources governance, and that is what this committee is. We are here today to consider House Bill 228 by Representative Mark Butler. A few housekeeping things. First of all, to members of the committee, the agenda for today is Representative Butler will present the bill, and other people on the agenda today is Mr. Lentz, David Tanner, Commissioner Walker, and Commissioner Meadows. What we will be about today is getting familiar with the legislation. What does it do? Why is it being proposed? How does it work? We will not be going through the 192-page bill line by line today. I know that's going to disappoint a lot of y'all, but at a future time, of course, we will be. And if there are things that we need to talk about the bill today, that will certainly be in order. But we're not going to move to perfect the legislation today. We will be having a public hearing on this bill Wednesday from 1 to 4 in this room, and there's a sign-up sheet and 245 of the Capitol, which is the appropriations suite. And I would request of members of the committee, as the different ones make their presentation, if you would wait until they finish for questions, unless you just got really some urgent matter right in the middle of it, and I will certainly recognize you if you do. Having said that, you know how the thing in front of you works. When you have a question, if you would press the button in front of you so we will know, and I will recognize you at the appropriate time. Representative Butler, if you would come and explain the bill. Yes, sir, that'd be fine.
All right, thank you. It makes it a little bit easier to spread all this paperwork out. Well, thank you, Mr. Chairman, members of the committee, and also thank you for not making me go over this bill line by line. And just as much as I'm sure that the members of the audience probably appreciate that even more than I do, because I'm sure everyone in here, including the members, have gone through all the whole bill, almost 200 pages worth, line by line already at least once. What I want to do here today is just kind of go over a general overview of what this bill is trying to accomplish. But a little bit of background first. There have been several of us that have felt over the last several years that we need to make some changes with some organizations with our health services, and that includes mental health. And one thing that probably stands out the most is you take a department as large as DHR is. You take a department that takes a look at anything from mental health to septic tanks, and that's a pretty broad area to take a look at. And we have been pushing for years to make a study to take a look at the department and possibly to change it around, move some things, maybe even remove some things altogether. And the governor was decided to get out in front on this about a year or so ago, and he formed a task force. And we met over the summer and had a lot of discussion. A lot of hard work went into it. We also had some public hearings, and what we have today is from all that work. And I'm sure everyone in here knows briefly, and those of you who are not familiar with DHR, and I know there are a few that of course, I'm looking up the members of the committee, and almost everybody who's here today I know is very familiar with all this, so I'll be very brief. The current structure you basically have is Department of Human Resources, which has mental health, developmental disabilities, and addictive diseases, aging, defects, child support, investigative services, ORS, public health. And then we have the Department of Community Health, which has health care, access, CON, Medicaid, Peach Care, and a state health benefit plan. What we want to do is take mental health and adult addictive diseases out of DHR, create a new Department of Behavioral Health using existing resources and structure. You notice I said existing resources and structure to create a new department, which that means we're not going to go out and add a whole bunch of stuff. We're not here to add government. We're just taking it and separating it out, giving it department level. And then we're going to take public health and move it over into what's going to be called the Department of Health, which is actually going to be a reformation of DCH and public health. And in there we'll also be planning and regulation and health care and finance. And then what you'll have left, instead of the ODHR, we want to change the name to Department of Human Services. People say, why do you want to change the name? Well, if you really think about it, when the general public, a lot of times when they hear DHR, Department of Human Resources, they think that's where you go to apply for a job, which that's not, which actually could be so in some years, but that's not really the purpose of what we're trying to get to. So we thought the Department of Human Services was a much better name. And in there would be developmental disabilities, aging, defects, and child support. Kind of the safety, some of that is a lot of the safety net functions of government. And that's basically a very general and very quick overview. If you've looked through the bill at all, and I know it's a very lengthy bill, and there's a good reason for that. As you know, if you look through it, it goes through just about every code section you can possibly imagine. And a lot of what's in the bill has to do with name changes. I call it the name game. Matter of fact, when I was doing my first read through, I got to one section, I believe it's on page, it's either 27 or 127. I can't remember which one, but it got to that one part to where it just got little one-liners and code section names and little name change, and it goes on and on and on. The first thing I thought of was those books in the Bible, like where you've got that so-and-so begot so-and-so, so-and-so begot so-and-so, and it just goes on and on forever and ever and ever. That's what I felt like I was reading when I got to that part. But the one thing that I want to applaud the governor's office for doing when they helped craft this bill, when they crafted it, was this little piece of paper right here. This right here is kind of like your Da Vinci code breaker right here. If you've got a question in the bill or something confuses you, use this as a reference. I had to use it myself. The reason is, a lot of times you're going to see things that are struck in the code section, and you're thinking, wait, why are we doing away with that? Well, as they say, stay tuned, because it comes back later on in the code section, and you'll see the references to that in here. So make sure you keep close attention to this right here, because this will help your reading and make it go a lot faster, and will stop a lot of confusion, and will answer about 90% of the questions that you're going to have as you go through it. Outside of that is just kind of a general overview. Besides the fact that we have 2 new coordinating councils that will be somewhat new. However, they're going to, again, use existing resources, and that's Behavioral Health Coordinating Council and the HHS Agency Head Alliance. These 2 functions that when we met on the task force, we thought were a great idea. The governor's office came to us, and the DHR department came with us with these ideas, and especially on the Behavioral Health Coordinating Council. This is something that, one of those kind of ideas, it's like when somebody invents something really simple and makes $1 million, you think, well, golly, why didn't I think of that? That was so easy. Well, this is one of those things. Why didn't we think of this before? One of the complaints a lot of people have, especially in mental health, is that we have mental health services through so many different agencies, and we have different you name it. We've got it through the Department of Education, DJJ, all these different ones have got all this. And what we seek to do with this Behavioral Health Coordinating Council is to bring all these department heads to the table and to work together to come up with a plan that works across all agencies, instead of having this one little pot over here and this one little thing over here and this one, and they don't really work together very well. Well, this right here, what we're hoping it's going to do is going to set the groundwork as we move forward to come up with a seamless mental health system that works across all agencies. I think this is a critical component to this legislation. It's an idea that we probably should have done 20, 25 years ago. I think if we'd done that, we probably would have a lot less problems today. The same thing with HHS agency headlines. It deals with health, coordinating health services, which goes more to your public health side. Similar type concept, dealing with just your regular, health questions. And that's kind of that in a nutshell. I can expand on any of that if you would like.
Any questions of Chairman Butler from members of the committee?
Now, tell me I didn't do that good a job.
Chairman Butler, I have just one question.
Sure.
Other than the coordinating councils, in terms of substance in the bill, I mean, I know the bill moves existing responsibilities around into different agencies and that type of thing, but and you mentioned coordinating councils. Is there anything else to speak of substance in the bill that's new other than moving them around?
We're talking about new agencies?
Well, no, I mean, anything in the bill that gives any existing agency some authority that they currently don't have, or takes it away from another one, or this and the other thing, other than the proposed movement?
Well, conceptually, no. However, when you take and you elevate a division to department level, then obviously they're going to get some additional powers, especially on behavioral health. So obviously there's some new stuff there, because when you elevate them up, then they are able to do things that beforehand they were not doing. But basically, you'll see those transferred. In their case, you'll see them transferred from the existing DHR over to behavioral health. Stuff like the ability to buy adjacent land and things like that, which the division really didn't have on its own, but now is it being department level. And there's also some look at some commissions that are sunsetting, taking out some language there. But as far as new, no, not really, not that much. But I'm sure that the governor's staff will highlight anything else that they may have a little more knowledge on some of that new stuff, because they crafted a lot of this themselves.
Thank you, Mr. Chairman. Did a good job. I have no further questions. Mr. Lentz. And obviously you may use whichever one you prefer, sir.
Thank you, Representative Chanel. I'm going to be, I think the committee members have a yellow folder in front of you. To all of you have that. I'm going to be referring you to some of the information in that, so you might want to look at that. Why don't we start, just for the sake of conversation, with page well, the first 3 pages of the bill are copies of Governor Perdue's executive order announcing the formation of the committee, and then the next page has the 2 organization charts on that. You might turn to that. So I'm going to talk from that just a little bit, not right now, but just in a minute. Last year, Governor Perdue identified the need to look at a restructure of the Department of Human Resources. And this was for a number of reasons, some of which Representative Butler mentioned. Changes in demographics and population since this department was formed in 1972 under Governor Carter, I believe, and all the other changes that you all know about. Also, it really came to our attention often during our budget conversations of just the scope and the complexity of the Department of Human Resources, and the fact that it had grown, and arguably I believe is probably the largest organization in all of Georgia state government. So that brought him to come up with this notion, this idea that we should look at the organization and see if there was a better way to accomplish what's being accomplished. He appointed the task force mentioned in the executive order, and we're going to try to show you, if we can, David Tanner, on the screen over there are the members of the task force. 9 of us, including 4 members of the General Assembly, Representative Butler, Harbin, Senators Unterman and Jack Hill, and then the other 5 of us there. The governor asked me to be the chair of this, and we held 6 task force meetings really over the spring and summertime. Following that, we held 2 public hearings in the fall, where we discussed our progress and what we the recommendation that we made at that time. Very early on in the process that we had, we established some guiding principles. I think they have a slide. They're really simple up there, but they were guiding principles that we stuck to. Do no harm, customers first, and live within existing resources. That is, no new money, and we understood that. I guess I have to say, frankly, that when we were doing this last spring, we didn't understand the significance of what we were talking about and where we find ourselves budgetarily. It's the right thing for us to have done, but we certainly did not have any aspiration to grow government. We wanted to be more effective and efficient and do so within our existing resources. We came into this, and I'm referring to your organizational chart. We just talked from it a minute. Representative Butler again talked about it a little bit, but we didn't have any preconceived organization structure. We didn't go in. The governor didn't say, "Here's what I'd like for you to accomplish." He didn't say, "Here's what I want it to look like." He said, "Go in with a clean sheet of paper and talk about it." So we had no preconceived structure at all. We looked at various structures. We looked probably at 3 or 4 straw man type structures as we went through our process. We looked at what other states were doing, how they're organized, how they're accomplishing their missions within the health and human services and health fields. And in our discussion of all of these structures, what we did was to identify the risk involved. We would look at a structure, we would put them up on the board, and we would talk through the risk involved with this structure. We would try to attempt to identify those, and we'd try to minimize the risk and to maximize the effectiveness of the organization that we put forth in our final recommendation. And that brings me to the organization structure, that proposed organization you have there in front of you. You know it. I'm not going to go through it with you. I really appreciate the fact that Representative Butler highlighted the 2 coordinating councils, the HHS Agency Head Alliance, which we believe is quite significant, and also the Behavioral Health Coordinating Council, because of the reasons he said. Anyone who touches the mental health field, the behavioral health field, we know that they have to have input, and we think this is a significant piece of this organization, even though except in the dots there and the ovals, it doesn't really show up on the organization chart. But we think this is the way this organization will run most effectively. This organization, proposed organization, we believe follows a couple of really what I believe are quite important principles, and what our task force came to believe are quite important principles. And those are, number one, the principle of focus. We knew that we had a burning platform in mental health, and so we focused on that intensely. We stood up. We proposed standing up a new organization to focus on that. And then the same thing with public health being under the new Department of Health. We felt like that would allow a statewide comprehensive health care strategy to evolve under the Department of Health there. And the second, I think, significant principle that we focused on was that of the management of change. There were other things we could have done. There were other things we could move. There were other things we couldn't have moved, but we felt like we had to manage the amount of change. To move from the existing Department of Human Resources to this proposed organization is a big deal. It's a very big deal, and we felt like that we pushed the envelope as far as we could on the amount of change that's appropriate and sustainable and that we can manage through. So after our meetings, and as I mentioned, and after the public hearings, this is our recommendation to you, and that's what has formed this bill, which Representative Butler talked to you about. I'm happy to attempt to answer any questions anybody might have.
Representative Oliver.
Thank you, sir. I'm a co-sponsor of your bill, and I support it. I've gotten a lot of calls about the Commission on Family Violence, and it caused me to go through the bill to try to understand, some from memory and some from your bill, other councils, commissions that have been created historically over time by legislation or by federal mandate. And a couple of them I've been educated by your folks were eliminated. For instance, the executive director of the Office of Women's Health was eliminated in your bill. A couple of things like that have been eliminated based on just budgeting over years. Then the General Assembly member, whoever passed that Commission on Women's Health, didn't know about it. I would like to know if y'all have a comprehensive list of councils and commissions that have been attached to DHR either by statute, federal, state, or executive order, and what's happened to all of them in this reorganization. Because I keep remembering things that legislatively have happened, and I'm looking for them and trying to compare whether or not the Commission on Family Violence is the only commission that's been eliminated, and I kind of think it may be, but I'm not sure.
I do not know the answer to that right now, but we can certainly get you a list of those, and I believe that's my understanding is, as you stated, that's the only one. But if there are others, we'll get you that list. I do not know the answer.
And in relation to those important functions, there probably are some other ideas that we can talk about that would protect those functions in a unified way.
I would certainly suggest that's the case.
Representative Manning.
Mr. Lynch, I appreciate this. This is something that we've been looking forward to for some period of time. My question goes to the money. How are you going to decipher what belongs to the Department of Health and what belongs to the Department of Behavioral Health? And when you do that, are the allocations, is it going to be like a melting pot, and you're going to allow the money to follow the person? Can you give me some insight in that, because it's in these budgetary times, as always, it's all about the money.
I understand that, and that's a very good question. We've asked ourselves that question a good bit over the past few months. The plan that we have, first of all, is, as I mentioned, is to stay within our existing resources, and beyond that, we would look at really the existing money, wherever it might be, and we would attempt to track it to the functionality and have it done what I would consider to be a professional financial basis. There will be changes. There's administrative money that, as you well know, needs to be divided up. We're standing up a new agency, the Agency of Behavioral Health. They have to have an administration, and some of that money will obviously have to come out of existing resources. And then within the Department of Health, the Department of Community Health has an existing infrastructure, as we all know, but they're taking on a new responsibility of public health. So there will have to be money moved around. We have a consultant working with us. As I mentioned, a transition like this is significant, and it needs to be done correctly, and it takes a while to do it. But we're trying to attach money to tasks and to individuals, and then place those individuals and those functions, those tasks, in the right place.
Well, I want to wish you my best.
Well, we need. Thank you. We need your good wishes and your prayers. Thank you.
Well, I
it's
hope
a big
it's loaves
task.
and
I
fishes.
recognize that, but we're. I think what I would say is we're very focused on doing it correctly as we possibly can.
Mr. Chairman, may I follow up just a minute?
Yes, ma'am.
And that's a major concern that I think I've expressed to several of your folks in the governor's office, that while I want to do no harm, I agree with that premise, but one thing that does concern me is that while we're doing this, that we don't do it to the detriment of some of the things we're trying to make sure that we don't hurt, and primarily I think is the cut to children and adolescents' mental health. That seems to be a great thing, as well as the waiting list and many others that I'm sure will come will come to fruition as we go down the board. And one thing that is always a possibility is that the General Assembly does have the appropriations bill, and it does start with the House members, and I'm concerned that somehow, I think we need to be at this table, and I think I expressed that when we had the Governor's Council on Mental Health, that perhaps a member of the General Assembly should be, the appropriations process needs to be involved in the Behavioral Health Coordinating Council, for lack of a better word. But I know we'll be working through all these things, and perhaps you have an answer, perhaps you don't. I'm not sure.
I don't, other than to say that we understand that on the other end of everything that this organization does as an individual, and our desire is to do no harm to those individuals and to do what we have been doing within existing resources. And as I say, that's difficult, but I think we can do it. We just aren't there yet. I don't have a document I can give you and say here's where the money goes, because we don't have that information yet.
If you'll take a look on the Behavioral Health Coordinating Council, there's actually, I do believe I'm correct on this here, it's not on the little bubble sheet, but it's actually in the legislation. It's near the end. You'll see that there is a member appointed from the House and the Senate, so that would be up to the Speaker and I'm sure he would obviously pick somebody from the appropriations process would be the natural place, because we understand structure and money better than probably most of the average members do. So there are some mechanisms already in there. I believe I'm correct on that. 154. It's on page 154.
Representative Houston.
Just to follow up on this Georgia Commission on Family Violence, didn't this used to be in DHR? And then it moved to the administrative offices of the courts?
I'm seeing heads nodding. That was before my time, if that was the case.
And now we're going, but why? I'd like to know why it was moved from DHR in the first place and then to the administrative office of the courts, and now we're moving it back. It seems like we're just running in a circle.
I don't know the answer to that, because we can get that information.
All right, I think it used to be then. I'd like to know why it was moved in the first place. And the next question, explain to me, the developmental disabilities and Department of Behavioral Health. Explain to me why developmental disabilities is not part of the Department of Behavioral Health. It looks like to me that has, just a name sort of, but we go in that way, just looking at the chart.
I believe that following me today, Commissioner Walker is going to be up here, and she's better qualified to do that. She has some data on that I'm sure she's prepared to discuss with you. I'd rather not steal her thunder.
Well, just when I think about developmental disabilities and behavioral health, it just seems like
I understand.
It flows.
That's where our task force started. Also, we have some Q&A about that we can provide to you, but I believe Commissioner Walker can help you a lot with that in just a few minutes.
I think it's in your yellow folder. There's a question and answer section.
Okay. I'll look at it. I hadn't read it
That's
yet.
the second question that was most popular that was asked.
Oh, it was? Oh, I thought I would just light bulb turned on.
Representative Gardner.
Thank you very much, Mr. Chairman, and I'd like to applaud the Governor's office for shining the spotlight on mental health and addictive diseases. I believe that these areas have been underfunded and the problems have been under-recognized in our state for far too long. We now have evidence that that's true, and we have an opportunity, perhaps an unusual opportunity, to see whether we can find some ways to help our mental health addictive diseases system work better. I mean, in all of this, I think the assumption is we're hard to imagine that we can do it with the same amount of money, but I believe that we need to be doing some things better than we have been in the past. The Governor's staff has been very generous with their time. I have had a lot of questions, continue to have some questions, but particularly concerned about the behavioral health section and how it's written to divide up what used to be House Bill 100 with regional planning boards and regional boards that are these, to some extent, the access for the DD population. And I don't think those boards are working particularly well. And I think there are some opportunities here to make that system work more efficiently, and I plan to submit some suggestions on how we might make that process better. But I think that section needs more work. Whether it happens in this bill or in a subsequent bill, I don't know. But I do know that the composition of the boards and how it all got shifted around needs some work in terms of the drafting of the bill. One little question, and some of you may remember who are on natural resources, we always talk about the septic tank issue and why the septic tanks are managed both by DHR and EPD, and who would do it best. So I hope you'll take a look at either one or the other, but why it should be in two different places so nobody really knows.
It's a great question. I've been here 6 years. I asked that question 6 years ago.
Good.
We don't have an answer yet, but
Pardon me?
good question.
It's in the health department, but it's also, right. I mean, EPD also has some responsibility. I have a lot more questions, but I will submit them to the governor's staff, and they've been very generous in providing answers.
Representative Hurd.
Thank you, Mr. Chairman. Thank you for your work on this bill. I'm sure all of us will have more questions, but one of my main questions today is, was there ever any talk during the process about combining, or should I say not separating, public health and mental health or behavioral health? And the reason I ask this is because as you look around the country, for instance, Tennessee and a lot of other areas, they're requiring more of your managed care. RFPs are requiring that there is an integrated system of care. And so since we're talking about reinventing this whole area of health care, was there any conversation about an integrated system between mental and physical health?
I believe that we discussed that. We discussed so many organizational models during the process that I'm fairly confident that was one of the ones that we looked at. I don't specifically remember that conversation. We did look, as I mentioned, at a number of a number of other states and how they were organized, but we came to the pretty firm conclusion on part of the task force that we thought this was the best organization structure that we could do with the least amount of change. But we did look at other structures. I just don't specifically remember that conversation.
Okay. And as we move forward, I have some numbers I would like to share, preliminary numbers, dealing with the people who are dual diagnosed, mental, physical, and the cost that they're costing the state. You will probably be amazed. And normally if you have a problem, it's that 80-20 rule. 20% of your people cost you 80% of your money.
Right.
If we could, as we move forward, look at that area of those who are costing us, and you will probably find that they are dual mental health, physical health, Medicaid clients.
Ms. Lindsay, I'd like to follow up on Representative Manning's question about the budget. Mm-hmm. I think I heard you say, and it is my understanding, that both DHR and DCH are there are consultants involved with trying to sort through what goes where type thing. Is that
That's correct?
That's correct.
Yes, that's correct.
But that task has not been completed.
No, it's in the early stages. We're further along on the potential public health transition than we are anywhere else. But we have an aspirational goal, obviously, upon a passage of this legislation, of having it happen by the July the 1st of this year. So we have a pretty aggressive time frame, but we're not there yet.
Well, again, just so what we're about today is trying to understand, the proposal and how it's going to work. But back when the task force was doing its work, a lot of that work was done in a economic time that was a long time ago. And Representative Earhart is a member of this committee. He's not here today, but I know one of the concerns that he has expressed to me and others is about the money. In other words, with a July 1, 2009 effective date, the General Assembly is being asked to approve these departments being shifted around, but we don't know, other than it's supposed to be revenue neutral. We don't have anything in front of us that does that. And I guess I'm asking, that's for some people a little bit of a leap of faith, and I guess I'm asking if let me put it to you directly. If we had a effective date of the bill of July 1, 2010, we'd have an entire year to sort through this. The governor and the governor's office would have an opportunity to put before this General Assembly a detailed budget, not something that's being studied, but specifically where the money is going. Isn't that true?
Well, I think, let me ask David Tanner. David, at what point do we propose having a budget that is 5 weeks? Within the next 5 weeks, which would be toward the middle to the end of March, we think we would have a budget that is something that we can recommend to you, and that is one that's more realistic than some of the numbers we're trying to work with today.
Would it be numbers that could be folded into the budgets that this General Assembly is currently dealing with?
That's my understanding.
And of course, I certainly don't know what the dates of when we're going to get through here, but a bill has got to go to the Senate or to the House or something in time to do that. But you're saying that this General Assembly will have detailed budgets before we are asked to act finally on this bill in this session?
Is that a fair statement, David? Yes, sir. Okay. That's what I'm saying.
All right, so Representative Gardner.
Thank you, Mr. Chairman. Your
second bite at the apple.
Thank you. Thank you for the second opportunity. Your question prompted me to think about, as the money is being divided up among 3 departments, and we have now 2 strong department heads of the health department and the public health. I've forgotten what they're
Human Services.
Human Services. Thank you. And there is no strong leader in the mental health, behavioral health department. So if you're dividing up money and 2 departments have strong leaders and one has no leader, it makes me really nervous about what will be left over for mental health. So I hope you will keep in mind or find a strong advocate for behavioral health and addictive disorders, so that whatever share is appropriate for those folks will be available to them.
I appreciate that. We're very cognizant of that, and we have a good referee for the money. That would be me. So we're going to do our best to make sure it's done right. But we also understand the requirement for a behavioral health leader. I understand that completely.
And as we are in the process of a privatization process in mental health, it complicates the issue quite a lot from my point of view.
Right. I agree with that.
Representative Manning.
I guess this is my second bite at the apple as well. I apologize, but I probably will take about a lot more, unfortunately, because I'm a little concerned about this whole thing. I want it to happen. I really do. But I'm just really concerned that it happened in the right way and that folks don't get lost in what will happen. And one of my major concerns is the privatization of the hospitals. If we're doing all this at the same time, and I'm just fearful that we're out there, and I know that the commissioner has indicated that it's really not an RFP, it's a RIP, or request for information,
RFI.
or
Yes.
whatever.
It is an RFP, though, isn't it?
It is quote unquote an RFP.
It was,
but it's still in the process. It's not.
That's correct. It's still in the process.
Okay. And that's my concern is that some of the hospitals, I mean, let's face it, the mental health issues are not the most attractive issues and not the real money makers. And so a lot of the hospitals really are not just clamoring at the opportunity to serve some of our folks. So I'm concerned that we're doing this all at the same time, and it's kind of like trying to get the egg back after you put it in the cake.
Well, I'm giving a lot of assignments to Commissioner Walker, but I'm sure she can talk about the privatization later on if you would like to do that.
Okay. Well, I'm just shaky.
Representative Howson.
One quick question. I think when we talk about dividing this money up, you said you had that there was a consultant for the Department of Community Health.
We have.
Could you tell me?
We have consultants working with transition helpers, I would probably prefer to call them, working with the overall transition. They're not necessarily working with one department or the other because they're the multiple departments involved. So they're trying to help us understand the organization, understand the flow of the money, and make recommendations on the best way to accomplish that.
Well, I think when Commissioner Walker came before one of the appropriations commissions, they said they had a CPA firm that was tracking the money.
I believe that's right.
Right. Does each department have a CPA firm, both community health and?
I know that community health does. I'm not sure whether DHR does or not. Commissioner Walker. They share. They share in the same.
They share.
Could
you tell me what firm they're using and where is it at?
I don't remember the name. What's the name of it?
Nichols Cawley.
Nichols and Cawley, is that right? Okay, Nichols and Cawley.
Could you tell me where
they're more, in my understanding, they're more of a, I guess what would be described as a forensic accounting firm. They're not a public accounting firm so much as they don't issue normal statements that we would think about.
Okay, Nichols Cawley. And where are they out of?
Macon.
Macon. Are they here today?
I don't believe they're here today, no. Hopefully they're hard at work doing what we need for them to do. Exactly.
Ms. Mills, I do not see any further questions. Thank you very much.
Thank you.
David Tanner. With OPB.
Thank you, Chairman.
Go ahead. I think I have to turn it on there.
Okay, thank you. Thank you, Chairman and the committee. I'm here today because I was asked to present some additional background. A lot of it's already been covered, actually. I was the staff lead to the task force. I represent a lot of work that was done by the House Budget Office, House Research Office, Senate Budget Office, Senate Research, and DHR and DCH staff as part of the task force work. We met almost weekly throughout this spring and summer to analyze the different proposals and options that were discussed by the task force. It was a great opportunity to collaborate and work together, and I really appreciate everyone's contributions in that work. A lot of this has already been discussed, but this is a presentation I put together for legislative training at the biennium, and some folks thought it would be helpful to level set everyone in terms of the task force recommendations. So if it's okay, Mr. Chairman, I'm going to just go through this as scripted pretty much, and it may be redundant to things you've already talked about. As you recall, DHR was created under Governor Carter, where we formed basically a consolidated human services agency. Since '72, certain functions have been divided out of DHR. For example, in 1976, the Medical Assistance Agency, which is Medicaid, was moved. And then later, DJJ was moved in 1992. And then in 2001, vocational rehab was moved to Department of Labor. And in 2004, some of the child care licensing functions were moved to DECAL. And then last session, you passed Senate Bill 433, which reformed the Certificate of Need process, which moved some of the regulatory functions from DHR to DCH. As mentioned, there were some compelling reasons to look at restructuring that the governor put forth in the executive order and that the task force discussed. One was to look at how we've changed as a state since 1970. In 1970, we had 4.5 million people in Georgia. Today, it's probably closer to 10 million. It's 9.5 million plus. The scope of responsibility has grown dramatically since 1970, as well as the population that needs to be served. And we wanted to make sure, as we studied this organization, we looked at structurally what would be best to fit today's needs and demands, as well as those in the future. And as Mr. Lentz noted, without incurring, or in terms of risk, that became a real key component in determining what structure finally went forward and the ability to manage that change. And this is an opportunity also to look at fiscal accountability in the lens of accountability for performance. If you have more focus, you can get better data fiscally and performance-wise. To highlight a couple demographic issues, which I thought were interesting. In 1970, children of single parents, 13.5%. In the 2000 census, 25.5% of children were in single-parent households. And I suspect in the next decennial census that number will grow more. U.S. Census data reports that children of single-parent households are 5 times more likely to receive government assistance. And so as that percentage has climbed, demand for services across DHR has certainly climbed. In terms of health outcomes and performance rankings, it's no surprise, you know this, Georgia continues to be in the lower quartile. And the task force recognized that certainly change in structure won't address this, but it's a good step towards bringing more focus and alignment of our resources around improving health outcomes. As we looked at other states, there was a great report put out by the National Conference of State Legislatures back in April 2006, which we borrowed considerably in our report. Every state is organized differently to meet their unique needs in their state. And in fact, since 2002, 50% of the states have looked at restructuring. So we're not alone in our desire to think about how to optimize our resources and governance. Basically, they fall into 3 camps. One's with multiple agencies that report to the governor, to the other spectrum which we currently have, which is a consolidated umbrella structure, and then various agencies somewhere in the middle between multiple agencies and consolidated. So our current organization, you know this, it's been covered today. I'm just going to walk you through an animation of how we see this new organization going forward with mental health and addictive disease moving out into behavioral health, and DD remains, and recasting that as behavioral health, and then looking at ORS and public health and moving them and reconstituting those programs with the healthcare finance and management functions at DCH into a new Department of Health. And as Representative Butler mentioned, we think changing the name alone will help clarify to our customers where to go for services with the new Department of Human Services rather than DHR. I want to also state that this model of agency alliance is really successful. We've seen some great improvements in our education agency alliance. Many of you may not be aware, but in the executive branch there is agency heads meet monthly or every other month by policy area. And so the agency heads of our education agencies get together monthly, and they have had a concerted target focus on improving graduation rates. And because they're coordinating monthly on that one outcome, we've seen a really good increase in high school graduation rates. Now, there's other things they've done. They've broken down barriers, they've aligned funding, they've aligned programs, they've they've actually thought about what's going to work to turn that performance curve in improving graduation rates. Now, that's the same model we want to replicate in our Health and Human Service agencies. Certainly, we want to prevent anyone from falling through the gaps or cracks in this process. And Representative Hurd, you mentioned the importance of coordinating public health being physical health and mental health. That's one of the purposes of this alliance, is that those agency heads meet monthly or bi-monthly to address service needs across their various areas of responsibility. We want to get cross-boundary coordination and a system of care, whether it's physical health, mental health, or human services and social welfare. We've covered a lot of this already, but the Department of Health, to put it in a nutshell, a three-part focus. One, to promote and protect the health of Georgians, plan and regulate healthcare infrastructure, and then facilitate and finance healthcare access and coverage. And we see some great benefits from having these programs aligned. The local delivery mechanism through your Board of Health, as well as the financing through Medicaid. There's a great opportunity to find alignment and synergies in those being together. There's also an opportunity to streamline some of the public health services and activities that currently exist in DHR and DCH, putting them together. And it does create one agency that's focused on access to care, as well as the issues of the uninsured, and providing a safety net, a physical health safety net for those folks. The department has identified that how they want to approach this work. Certainly it's a local approach. Through the local counties and regions, it's important to meet the specific health needs in each area, in each community, with targeted investments to the needs at the local level. And collaboration is critical between local governments, the state, the federal, nonprofit, and other community partners. Getting all those folks at the same table, I think, is a good way to do the work differently to improve health outcomes in Georgia. And then the quality delivery of care through management and regulation. These other two slides are provided to you in your packet just for background. Bullet points about other synergies and opportunities of having public health and Medicaid together in the same agency. As Chairman Butler mentioned so well, and Mr. Lentz, there's a really urgent need to do things differently and focus the lens of improvement on mental health and addictive disease. And this agency, we believe, will do that. There's things you can do structurally to bring focus, and having an agency focused on that one aspect, we think, will bring performance accountability as well as better fiscal accountability for how those resources are used. And finally, in human services, we looked at all the different organizational options out there, but this presents an opportunity for us to have a focus in two areas with this agency. One is on long-term care, developmental disability customers. That's a lifelong care issue. Same with those who enter into nursing homes and need aging services. That's a lifelong care issue. And then with family and children's services and child support, this is an opportunity for this agency to really focus on protecting and supporting families in Georgia. As I mentioned, the name make it more intuitive, and as well as trimming down the scope brings more focus to both fiscally and performance-wise, as well as capitalizing on some of the process improvements that we've seen at DHR. We hope to see that continue going forward. We've talked about cost a lot, and Mr. Lentz and Representative Butler have mentioned this. We are looking at the cost from a zero-based budgeting perspective. We're saying what's the right administrative activities and functions to support three agencies, and then looking at what's currently there and what the workload is of all the people who work there. I'm confident these accounting consultants that we've engaged are going to provide the kind of detail we need as budgeters to allocate the resources in the proper way. Since you're all on appropriations, I thought an illustration here of how the budget will be divided up would be helpful. I don't expect you to be able to read this, but it's more for illustrative purposes. Each box on this chart I'll just point out with my laser pointer up here, the boxes along the top, these are more like divisions, just to help me keep it all clean. The boxes underneath the yellow bar are all programs in the appropriations bill. There's 43 programs in DHR, 8 programs in DCH. The yellow programs identified up here are where there is money that would need to be split up between 1 or 3 of the agencies. So as we look at the restructuring and so forth, first, let me just animate this here for you. These programs right here are the programs that fund and deliver services in mental health and addictive disease. Those are already budget buckets, if you will, in the Appropriations Act. These buckets here, these are program budgets related to developmental disabilities, aging, DFACS, and child support. Those budgets, as you appropriate them, whatever money's in that budget bucket would be moved to the Department of Human Services. And then these buckets here, I'm sorry, colloquially I'm just calling budget buckets. It makes it easier to remember. Those budget buckets, some at Public Health, some at Regulatory Services, and the ones at DCH would all move into the new Department of Health. So you can see program budgeting actually makes this budget movement fairly straightforward. Whatever you appropriate to that bucket, we're going to pick it up and move it to that agency. So budget cuts will go on because we have to cut the budget to meet revenue. But whatever's going to be in that bucket will be picked up and be part of that new agency. The items in yellow, the administration program, a portion of the regulatory services right here, and then this yellow one over here between DD and behavioral health, that budget funds the support services at the hospitals. And so the DD money in that program would need to come out and be part of behavioral, would be split up between behavioral health and human services and in the DD functions. So it's those yellow boxes right there that our accounting consultants are helping us with, digging into the details of who does what, how much work is involved, what are the processes, to help us make a good judgment about where it should be in the future, how much money should be in each bucket, in each agency. And so I hope this demystifies a little bit of the budget allocation process for you. If we stay true to the appropriations process, those buckets are what they are when the legislature's done, and they'll be moved. And then OPB will be working with you in the Senate to best allocate out the administrative dollars proportionally to the workload. So in terms of next steps, this bill and then transition planning is moving ahead with staff from DCH, DHR, and others as we look at moving those functions from one agency to another. Chairman, that's my presentation. Thank you.
Mr. Tan, I want to ask you a question, and it would also be directed at Mr. Lentz. In terms of the overall goal, I think I've heard both of you say that included effectively downsizing DHR because of demographic changes and scope of what they're having to do is one of the things you wanted to accomplish, and also to focus a lens of improvement on mental health and public health, and therefore they were in y'all's proposal is moved out of DHR. Is that a correct statement?
I think what we wanted to do is...
I'm not saying that's what what it's entirely limited to, but I'm saying is it true that you wanted to take public health out of, proposing to take it out of DHR as well as mental health?
The early strawmans the task force looked at, there was one common theme among all of them. One was public health. We need to address where it is and how it's governed. It doesn't work where it is right now. Okay. The other common theme was mental health. Okay. Something needs to be addressed there. Okay. I think the committee, yes, in general, the task force all felt like what we have right now is too big to manage.
Okay. Thank you. I just want to be sure. That's what my understanding was. I want to be sure that I was understanding it correctly. Representative Houston.
Thank you. You said public health is not working. In rural areas of Georgia, public health provides more services per person than any other health that we're
Let me
getting.
restate. I didn't say it's not working.
Maybe I misunderstood. Did you say, what did you say?
From a governance standpoint, it's fairly different from, as Representative Butler mentioned, septic tanks to mental health hospitals.
Okay.
There's a lot to cover.
But I thought you just said public health is not working. Maybe I just took it out of context. I'm sorry.
Thank you.
I've got a soft spot in my heart for public health, so I had to stand up and defend it. Thank you.
I didn't mean that in any way. I'm sorry if I misstated.
I see no more questions. Thank you.
Thank you.
Commissioner Walker.
Good afternoon, Chairman and members of the committee. I'm really going to devote most of my time to answering specific questions, which I'm sure you have, but I thought it would be helpful for you as the person who's been responsible for almost 5 years now of running the Georgia Department of Human Resources to talk to you about my perspective on this journey that we're on. And the way I like to characterize this journey is a journey to restructure health and human services in Georgia. DHR happens to be a large footprint, a pretty gargantuan footprint in the health and human services arena in Georgia, but it's an opportunity for us to see if we can put together a set of organizations that have an opportunity to move the ball even farther down the court than it has come. Many of you, I'm sure, were part of my presentation to the Joint Appropriation Committees. And I tried to take that opportunity to talk about where I think some of the strides that have been made in moving forward health and human services in Georgia. I think that this restructuring offers a unique opportunity to take an agency that has made great strides and make greater even strides, and it's an opportunity to restructure for Georgia of tomorrow rather than the Georgia of 36 years ago. In my career, I've been on both sides of this situation. In Illinois, I worked for a Republican governor who wanted to consolidate all of the human services in that state. And we did quite a bit of work and managed to create an umbrella agency quite like DHR. At that time, it worked for those times. I think this particular restructuring works for the times that we're in. The major issue I think we have a strategic opportunity here for is focus. I've been very focused on execution across all of DHR. We've been very embedded in using the Covey principles of execution. We've used rapid process improvement out of Georgia Tech, and we've been able to, by focus on some of the things we want to change, make great strides in execution. I think this plan has the opportunity to present that across the arenas. The other thing I think is really helpful about what we're looking at is the customer is really the primary driver of the new configuration. What the customer of that particular business model is, who it is, what they need, I think is really the driver around the configuration that we have in front of us. For example, in the health arena, the prevention, the promotion of good health, the protection issues that are part of that business model, I think get a unique focus. In human services, the fact that we can intervene and support people who have vulnerabilities. Some of those people have short-term vulnerabilities. We need to be in their lives and we need to be out. Some of those folks have long-term vulnerabilities. We need to be in their lives a little bit or a lot over the course of perhaps as long as a lifetime. That, I think, is the business of the new Department of Human Services. And the Department of Behavioral Health is really focused on treatment and recovery for an illness, a disease, two illnesses actually and diseases. One, mental health, mental illness. One, substance abuse or addictive disease, whichever one of those you use. Will this be challenging? And I've gotten a lot of questions about this. Absolutely. It's going to be challenging. But just because it's challenging doesn't mean it isn't the right work to do. And just because it won't be perfect, I think the president quoted the other day, we shouldn't make the perfect the enemy of the necessity. And I think we're at a point of necessity. In many ways, it's the best time to do this because we're in a situation where we can see very clearly some of the things that we would like to see done in a model of execution. So I say that as a sort of opening. You've heard all of the other details. I certainly don't need to go over those with you, but I'm perfectly willing to answer any questions you may have that are specific to my perspective on what we're getting ready to do.
Representative Gardner.
Thank you, Mr. Chairman. Is it your opinion that this reorganization will save the state money?
It is not my opinion that it will save the state money. It is my opinion that it will help the state spend the money it has more effectively, more efficiently, and that for every dollar we put out there, the fact that we're able to focus and really focus on the execution of key things, and that you have 3 different leaders doing that work, you're going to get a better bang for your buck.
And if it will provide better services for those people, then aren't we wasting money if we don't do something this session?
I don't know that I want to comment, and I don't know that it's appropriate for me to comment about whether you ought to do it this session or not. I think that from my perspective, we're in a position to present to you a plan and a way to execute a plan to do something in this particular session per the governor's desire that we get this work done and we move on to the next phase of it. That would be my take on it, but I don't know that it would be appropriate to say whether or not, as the General Assembly, how you might choose to decide.
Representative Howson.
One quick question. Privatization of the hospitals, mental health hospital, is a major thing. Well, we're proposing to make changes in mental health and have a whole new department. Why are we going to think about privatization before we move this out? What's the rush?
Well, I'm not sure that it's a rush. One thing we were asked to do last summer, actually a year and a half ago, the legislature asked me to look at privatization. And I think at that time a resolution was almost passed that would require me to look at privatization. And I had a number of conversations with a number of legislators about how we had not, as a state, looked at it, and perhaps it was time we looked at it. So taking them up on that issue, we began to explore and have some conversations that would help us look at this issue. Last summer, the governor asked us to give him a game plan, to tell him what is the end game here, because when you're making investments and trying to make decisions, you need to know where the goalpost is. And so we started to work, Gwen Skinner and her staff and I started to work to begin to think about what kinds of things ought we to look at in this new system. As we began to present a game plan to the governor, the economy of the country began to go south very quickly. So what had started as a game plan to suggest what our funding needs might be turned into a game plan to figure out how in the world are we going to run the very best system that Georgia deserves at the same time as we look at these challenging economic times. And then we sort of had the perfect storm of 2 agreements, an Olmstead agreement, which we signed, which says that we will move at least 150 people with developmental disabilities out of living in hospital institutional settings over the next few years. At the same time, we also signed an agreement with the Department of Justice to think about how do we enhance and to implement the enhancement of quality initiatives in our hospital. When you begin to think about all of those urgencies, it's like fires lapping all around you. So we had the option, let the fires burn, or we had the option of beginning to say, what do we have in our resource kit, and how might we think about utilizing those resources to address these urgent issues that we have today. I think our intent is that we're going to do the very best we can to think about the options that might be available to us. How do we effectively and efficiently spend the dollars we have and use them to improve the system at the level of expectation and to get the agreements that we've signed implemented? And that's what we think we're doing. So there's no rush. The game plan that and the privatization issues that we've talked about, one, we've said consistently, there will be no privatization if we don't get viable bids that we think actually add value to the state's ability to deliver services. So there, an RFP is just that. It's a question. If you don't like the answers, you keep doing what you're doing.
Just from, outside looking in, it looks like a major step for somebody to make when it's supposed to be taken out of their department. And
well, this I'll say to you, what would be a sad step is to sit here and do nothing.
Oh, no.
And to not try to make the very best of what you have. The game plan is not a rushed plan. It's a 4-year proposed way of looking at using a variety of strategies. The biggest problem we have in Georgia, and we had a summit, and we brought together a host of mental health professionals from all walks of life, and we met here in Atlanta about 1.5 years ago. And out of that came one resounding piece of feedback, that Georgia does not have enough community-based services. We don't have ACT teams. We don't have enough 24/7 crisis stabilization programs. We don't have intensive residential treatment facilities for people so that they can begin to move out into the community and not live in state hospitals. We don't have detox. We hardly have any detox resources at all across the state. All of those things were put on the table and suggested this is what we need. So what we did was try to take the resources we have. Now, I take no shame to that. If you got 50 cents when you walk in the store, you got 50 cents. You can't buy 60 cents worth of something with 50 cents. You buy your 50 cents worth, but you make your 50 cents go as far as you can. So we've taken the resources we have, and we're stretching them and using them to provide what we think people with mental illness and addictive disease need. And we are trying to put proposals and actually working in an environment to see whether these things work. We have one advantage. In Columbus and Savannah, we have extra dollars in this budget that we could invest there without doing anything to the hospital up front. So we have put community services in those two communities, and they're having a clear impact on what's going on in those hospitals. Is it perfect? No. But is it proving, perhaps, that if you have these services, you have less demand on the hospitals? I think it is beginning to show that. So that's where we are. We're not in a concrete plan. We're in a very evolving and flexible way of thinking about how do we use our current resources to do a better job than we're doing now.
I see no more questions. Thank you, Commissioner.
Thank you.
Commissioner Meadows.
Good morning, Mr. Chairman, members of the Special Subcommittee. You know that it would not be a meeting with me without paper. This afternoon, I wanted to provide you with a couple of pieces that I hope will be helpful in your consideration of this proposal to create a Department of Health. I wanted to say from the beginning that we're talking about health and human services programs between 2 or 3 different agencies at this point, and the creation of another or reorganized 3. But I also wanted to say that these are all agencies who have a mission of improving upon the human condition, whether it be the public health or population health across the board, whether it be health care services to individual people in a health plan, or whether it be the provision of adequate and important behavioral health services, as well as safety and regulatory services. They all have a common mission, and that is to improve and to be the caregivers for improved health care for the individual and a healthy Georgia itself. What you have in front of you is a handout that has 6 slides that I want to speak to. The remainder of the slides are actually background and reference material that you might find helpful when you review this proposal. The first slide after the cover slide is actually the same organization chart that you've previously seen, the before and the after. The before of what we look like and the recommendations in House Bill 228 of the after. And what I want to focus on is what's in the right-hand corner, the Department of Health, which would include under this proposal public health, health planning and regulation, as well as those programs that are provided within the current Department of Community Health, Medicaid, S-CHIP, the State Health Benefit Plan, Rural Health, and Health Planning, as well as Certificate of Need. On your next slide, I thought this would be helpful to you as it was to me. And essentially what it includes, and again, I'm sorry for the people in the audience, these slides will actually be up on the department's website for your viewing as well. But what is on the next slide is actually, for your review, the 3 different groups each have a mission statement, which I will read for the benefit of the audience if you don't mind. For the Department of Community Health, the mission is to champion access to affordable quality health care in our communities, to promote and champion responsible health planning and use of health care resources, and to also address and promote healthy behaviors and improved health outcomes. This includes, for our department, the work that each member is to achieve in development of policy and program, healthcare benefit design, healthcare outcomes and quality improvement, program and vendor oversight, member and provider services, financial integrity, as well as prospective planning for the health plan members, as well as for the people of Georgia in general, and as always, budget. It also includes the healthcare facility planning and certificate of need, as well as health access programs which address rural health. Under the Office of Regulatory Services, and this is taken directly from their website, the mission is described as follows: to promote the delivery of safe and healthy services by regulated providers through our information, inspection, and enforcement efforts. The Office of Regulatory Services inspects, monitors, licenses, registers, and certifies a variety of health care and long-term care facilities. They also today address children or child care facilities. For the transition that is recommended in the governor's budget as well, in the House Bill 228, this would include regulation and safety of hospitals, ambulatory surgical centers, home health centers, home health care, nursing homes, and labs. And then the last one is the mission statement for the Division of Public Health as it stands today. And its mission, again from its website, is to promote and protect the health of people in Georgia wherever they live, work, or play. We unite with families, individuals, and communities to improve the health and enhance the quality of life. The 3 basic functions as outlined for public health are to assess the health status of the population, assure that people have the resources and skills necessary to remain healthy, and establishing and implementing sound public health policy. I put all these together for you to see in one page and one sheet because I wanted to talk about that they are distinct and very important aspects of health and health care itself. However, they do have one common goal again, and that is to have healthier people and a healthier Georgia. To be truthful, we all know that each of these programs, no matter which way you divide them, and they can be divided up 6 ways to Sunday at this point, but the most important thing, more important than where they reside, is that they actually be effective in what their goal is and actually achieve their missions. That is more important than anything else, and it is definitely more important than what we call it, where we put it, and where we place it. They have to be effective. Your next slide is a very simplistic view, and I understand that, but it's where we have to start, and that is what the combination would look like. The components of the new Department of Health as proposed in House Bill 228 is that it include all of those programs as listed within the Department of Community Health, public health itself, and healthcare and long-term care facility regulation. The next slide I thought would actually be more helpful to you when you actually look at what is within each of these three segments. So those 4 different green circles that represent public health, they include the population health monitoring and planning at the center. But if you look a little bit to your right, you'll see the blue circles that actually represent the key areas of the publicly funded healthcare programs run within the Department of Community Health. So right next to population health with monitoring and planning is health policy and benefit planning that we have to now do within the Community Health Department itself. And we are doing it for a segment of the population, that is true, but it is a very important segment of the population. There would be benefit to us if we could actually take the learnings, the monitoring and the study that is done in population health within public health and be able to apply those learnings when we do our own policy development, health benefit plan design, and assessment of our populations in State Health Benefit Plan, Medicaid, and SCHIP. In addition, there is additional overlap in our programs that involve healthcare access in general, and in particular to rural health itself. If you also will look, you will see that within the public health circles of care is the provision of disease prevention and clinical care itself. Right across from that, on the publicly funded healthcare segment, is the payment for such services, whether they be episodic clinical services or whether or not they be primary care that is provided to individuals in the communities at the county health department level. There are more than enough areas that we could connect, areas that we could actually develop synergies on, care that could be coordinated, and finances that could be better and more efficiently applied that we actually can see just from the outset. We anticipate, however, going forward that we will learn many more opportunities for improvement as we develop a new Department of Health. The next slide under the after the circle diagram is a description of the new Department of Health. What we see is the opportunities as well as what we see as the success factors that we would need to achieve. Under opportunities would be, number 1, the alignment of Georgia's health and healthcare goals by coordinating community healthcare programs, public health, and health-related regulatory functions. Second is the coordinated resources across public health and healthcare outcomes for Georgia. Number 3 is provide a central point of contact for health policy, health planning, and healthcare services. We know that not all of healthcare would be within the Department of Health in this particular model, but we think that key elements would be. We also realize that to try to put all of the elements that involve healthcare into one giant agency would kind of defeat the purpose that's trying to be addressed with the split up of DHR. In addition, number 4 is to improve capacity to meet unmet healthcare needs by fortifying and coordinating the healthcare safety net system. This is critical to us at the Department of Community Health, and we also believe it is critically important to the leadership that is currently leading public health itself. As the unemployment goes up, the number of uninsured rises, the number of underinsured rises, the number of individuals who are going to be seeking help and assistance. We want to focus on actually fortifying and strengthening the safety net as it is today and improving it going forward. And we believe that the model that we are presenting to you in this proposal will help us best achieve that. Success factors. What do we need to have in order to be successful? I took the first bullet off because it had a $sign, and I figured you wouldn't be too amused right now with that. But the second thing, most important, would be time. Right now, our focus is on transitioning. We've already begun the transition work for the health care facility regulation part that actually began shortly after the bill passed, Senate Bill 433, moving regulatory services, key elements to us. So that work is already underway. But with respect to the public health portion, our work is focused on transition, not transformation. Our goal is actually to have in place a complete transition by July 1, but again, it is transition, not transformation. What we are trying to do is move public health the way it is today, maintain it. Our big goal is to actually avoid service disruption or program disruption. This is critically important because it does also include emergency preparedness, along with all the other services that take care of individuals today. Transformation is something that will take time. It will take a lot of time. It will also take a tremendous amount of input in order for us to do it right. We're going to be talking about developing a new Department of Health, not a merger, not an acquisition, but developing something that is new. And that is going to take time. We're talking about learning where the efficiencies are, where the synergies are, and actually having to come up with what we want the overall program, or department to look like. Second is resources. We are currently doing an assessment of department funding, both of the current Department of Community Health as well as looking at public health and ORS. Nichols Cawley's and Associates is the entity that we have hired. They have done a tremendous job for us in addressing the admin and financing situation for regulatory services, as well as doing cost allocations for our department in the past. This is a bit more of a challenge for them, but we believe that they are up to it. We have received a draft of their initial methodologies that we'll be reviewing with them this week, but we will not have financial numbers until March. Nichols Cawley's is a certified CPA, financial auditor, financial planning, and valuation firm. Third, collaboration. As important, if not more so, than the first two items on the list. Without stakeholder buy-in, this will not be successful. This is tremendously important to us. We are talking about moving 3 distinct areas of health and healthcare services into one department, and it will take leadership from all different areas to come to the table. It will take their expertise, knowledge, and experience. Included in that collaboration needs to be not only what happens here in Atlanta at the state in terms of the capital, staffing and resources, but also bringing to the table county health departments and county officials. So it means that we will have to go to them and learn and bring them in and show them what it is that we were able to provide to support their efforts in taking care of the people of Georgia. The next slide is with respect to key elements of transition, work that is already ongoing. Part of the work going forward has to deal with, after we have looked at our budgets backwards and forwards and sideways, so look for budget reductions and efficiencies to address the amended 09 and 2010 budgets, is also to look at what we would need to address in terms of having a successful transition, avoiding service disruption. Operationally, we've had to develop approximately 10 different work streams to address the multitude of issues in bringing public health and community health as well as ORS together. So on your list is a list of the different work streams, just to give you an idea of the magnitude of the effort that this is taking. In addition, the Governor's Office has hired a project management team to work with us in coordinating operational assessment needs. We have a draft plan from the consultant that we will be reviewing this week as well on the timelines, deliverables, etc., on implementing the transition. And then next is a financial assessment that I think has been mentioned several times, being performed by Nichols Cawley's for this department, as well as for DHR and the Governor's project manager as well. The remainder of this handout is simply reference material that I thought you might find helpful. It includes in it a listing. I know that some of you will be surprised, but we do actually have clinical or medical professionals at the Department of Community Health. I thought it'd be helpful for you to know where they are. About 10% of DCH staff are clinicians, and they actually address everything from policy development to program design to health benefit design, clinical reviews, as well as clinical outcomes and quality improvement programs. Also in your packet is an inventory of public health program inventory, which came from OPB, a copy of the public health districts from public health itself, a survey we conducted of county health departments asking them about their interest in clinical care services and primary care, a map of the Georgia Safety Net clinics, and then a fact sheet about the Department of Community Health. Mr. Chairman, that concludes my remarks. I'm happy to take questions.
Representative Oliver.
Thank you. I agree that we can make any number of arguments about where to move the boxes. And I'm going to ask you just a couple of questions. Maybe you can specifically tell me what your understanding is on a couple of different programs. Under regulatory services, existing DHR regulates foster care, group homes, child treatment organizations. Do you assume if those regulatory services move to you, department, a new department, that those exact staff with those experiences will move with you?
The child care services would actually stay with the Department of Human Services.
I'm talking about the child treatment centers, like Chris Holmes, like Devereaux, like do you know? So you don't have that expertise with those kinds of child services organizations, but I'm assuming
we don't have the expertise. But they would not be moving with us. They would not be moving to the Department of Health. They would actually stay with the. It's not all of ORS. It's only the health care facilities.
I think the charts are confusing me because the charts seem to say that several of those organizations are moving over. So maybe I'm wrong.
No, it is confusing because it's actually all of the child and child health or social service things would actually stay with Commissioner Walker.
Under this piece of paper I'm looking at right now.
Which one?
This is one of the governor's staff. Child caring institution, child placing agencies, transition child care.
Does it say DHS or does it say DOH?
DHS.
Department of Human Services, which would be her. Oh. I would be Department of Health.
What about supportive housing for the mentally ill?
Does that go with you?
If a function is moving, is the staff moving with it? Is that what you think?
I'm sorry?
If a function is moving,
staff is staying with
the same staff is moving with.
Yes, we would not be creating new staffing, new positions. Everybody's going to move like they are today.
Okay. Integrated family support started out with public health, and now it's being moved to DFACS. That had been a public health program, and now it's moving back. Do you have any? Do you know about that program? Do you have any sense of whether or not it's really a preventive health program that fits with public health, or whether or not it's?
I do not, Commissioner Walker.
Integrated family support was really a program between public health and DFACS, funded with TANF dollars.
Mm-hmm.
And when we originally put the program together, what we were really trying to do was to expand public health's notion of its involvement in child abuse and neglect.
Which I support.
Oh, I understand.
And now you're going back.
Commissioner Walker, do you mind joining your fellow commissioner up here as well?
No.
Anybody might be interested in this on the internet that can understand what you're saying.
Sure.
Put a chair there for the mental health commission.
Thank you.
Empty chair.
Mm-hmm.
Integrated family support was actually an approach and an activity that we developed between the Department of Public Health and DFACS. Its goal was to begin to move a system for helping dealing with people on the front end of a child welfare system who may not have been involved in abuse and neglect, but it's preventative for a family at risk of abuse and neglect. When we began to understand how that program was going to roll out and who were the providers who were going to be utilizing, who were going to be trained and using the program, it made more sense, given the reorganization, for it to remain at the front door of DFACS, because the majority of those organizations are really the child agencies and the family preservation agencies that we're working with in the child welfare arena. However, we still believe, and I believe Dr. Meadows and I will have no problems figuring out how do we, on the ground between public health counties and DFACS offices, continue to maintain and sustain some work around prevention of child abuse and neglect. I don't think that work has to go away.
The challenge for this structure, in any structure, that's going to make a division. The challenge is, in my judgment, your low percentage of success on EPSDT compliance in terms of the national level, which is a preventive child health, and the need to do more prevention child abuse programs. So you're going to have EPSDT, and DHRD is going to have child abuse prevention, and that's a challenge, is to make those prevention services work effectively.
But I will say this: I think integrated family support is some small dollars out of TANF to try to get some training and some other things on the ground and an approach. I still think that we should be thinking about, and hopefully in our health and human services arena, as we've been working on indicators, one of the indicators we're looking at is really some of those front-end indicators. So I would not expect that a reorg eliminates the possibility and the potential for working together across these boundaries, and that HHS Alliance is intended to bring about some of those working across the boundaries. If we lose the ability to leverage through this reorg, it will be a loss indeed. So I think we need to work actively to create that synergy and to keep it in play.
Representative Manning.
The commissioners, are y'all going to be friends after this is over?
I don't know.
She's laughing. I'm beginning to wonder myself.
Representative Manning, this is a trial run for the reorg right here.
Well, y'all needed one more chair up there for that poor soul that's going to get behavioral health as their thing. But seriously, I think this sounds wonderful, but I'm concerned about this accounting firm, giving you the numbers on a forensic counting, and then you're being given the job that you've outlined and being able to do it. Especially in regard to public health. That's a huge one, and the privatization of the hospitals and taking care to make sure all these folks don't just get in dire straits, and our developmental disabilities folks that we worked for so hard to get off the waiting list, and now we're having people that are saying they're not going to get services because not enough people. For lack of a better word, not enough people had a change of venue, which is kind of problematic to me in a way. So, I wish you my very best, as I said, but I'm really concerned that all these different stacks are going to work out, and that we shuffle the cards. We're going to have a collaborative system that will give Georgians good health and good health practices. Yes, ma'am.
If we are looking particularly calm, we're not. We have concerns as well about getting the work done. We know that we have a target, and we intend to succeed in that target. But we know that when we have the report from Nichols-Cawley, it's going to show us what we all pretty much can guess.
Right.
Underfunding.
And we haven't looked at the formula since 1972 or something?
Yeah. But what we need to do is go ahead and just bite the bullet, do the math, figure out what gets funded what streams are actually appropriated for what, map it out, and then actually look at what then do we need, if anything, above that. No, we got to be very clear about that. We're looking at what exists today. And then part of the transforming process is figuring out what we will need going forward.
In some ways, there's the song that says, trouble don't last always. Though when you're in trouble, it seems like it's lasting always. To back up what stop it. To back up what Rhonda is saying, we have been struggling. Let's be clear. I've been here 5 years. I've been struggling every year to have enough money to do all the things that I think we should be doing and that the people of Georgia need us to do. We've been struggling. And so the struggle is different now because fiscal times are more dire than they were, but the struggle continues. And at some point, I would expect these fiscal times we're in to not be permanent. And so at some point, we're going to be putting a 2011 budget together. And I'm hoping that we're going to be putting together a budget that has allowed us to think transformationally about what ought to be on the table, and to take the very best ideas from this bad time and turn them into some great ideas in good times. If we couldn't hope like that, let me say this to you. If you couldn't hope like this, you couldn't do this job. You'd be in the fetal position constantly, and you wouldn't come to work. Rhonda's been known not to do that.
I think I'm in that position.
Yeah.
Can I, now that she's depressed you,
I need some help.
remember the saying about out of adversity comes opportunity, and this is an opportunity for us to do what's right going forward. We know that the mental health system needs to be fortified tremendously. We know this. And this is our chance to do it and to do it right. We know that public health needs support. It does.
Yeah.
What mental health is going through today, public health is one natural disaster, a man-made effort, attack. That's what we'll be with public health. So we don't have any room to mess up. I'm not going to use the president's word, but you kind of got the flavor of it.
We have several more questions, but I'd like to jump in on the, again, going back and Mr. Lentz, on the money part. With a July 1, 2009 effective date, we passed this legislation, but then the consultants thing doesn't really come in March. It comes in April, May, and y'all can't agree, and somebody can't agree. What's our posture? I mean, who's going to split the money up if we don't? If we pass this bill without numbers in front of us, what's the consequence of that? I mean, who's going to make that decision? And it's probably a question for Mr. Lentz more than anybody else.
Mr. Lentz said that Commissioner Meadows has the final say.
Well, now we finna fall out.
Well, what? Well,
let me just be clear.
I'll answer that. First of all, I don't think that will happen. Nobody's naive.
I'm just posing that as a what if.
Fine, and nobody's naive enough to think this is easy. It's not easy. The money's not easy. Hey, the money hadn't been easy the 6 years I've been around here, whether we had a lot or we don't have any, is it such as the case this year. I would imagine that if we can't get the numbers that we're comfortable with, then the governor would make a proposal, a very specific proposal, as to how the money would be split up, and you guys could react to it. That would be my answer.
Well, again, let me rephrase that. If we pass the bill and it's effective July 1, 2009, but the information from the auditors, I mean not the auditors, but the consultants and all that, doesn't come back in time for this General Assembly to put those numbers in the budget, then what would happen? Who puts the numbers where they're supposed to go?
Well, I think we're going to get the numbers. I hadn't really thought about that, to be perfectly candid. I mean, we'll come up with a scenario and come up with an answer to that. I don't know it right now because I don't really think that's going to happen. I have confidence that these folks will.
You're not asking us to pass legislation doing this without the General Assembly seeing the numbers.
No, we'll have numbers. We'll have numbers for you.
Okay, thank you.
I would also say, since you phrased that question, that I believe, frankly, that given the fact that we've taken the time that we have, the last 6-9 months, to prepare where we have come, and given the fact that we have, I believe, an organizational structure that is superior in service delivery potentially once it's stood up, that it would be a real mistake to wait another 12 months. I just think that would be a shame. I think that you'd have an awful lot of chaos. You'd have an awful lot of people's questioning where they fit within organizations. And my experience is that the longer something like that lingers, the worse it gets. So you need to have tight deadlines, and transitions like this, and you need to execute within those deadlines as best you possibly can, understanding that it's difficult. So I would want to go on record as saying that I think a 1-year delay would be a real mistake.
Well, listen, the chair agrees with you that we need to have realistic deadlines,
right,
and numbers. Representative Hurd.
Thank you, Mr. Chairman. I'm kind of on this one track here about integrated health services. And my question to both of you, and I guess we don't have the mental health person, as been mentioned earlier, is not here at this appointed time, has not been appointed, but how do you see an integrated system working? And I totally agree. No matter what structure we have, if we're not talking across lines, if we're not communicating public health, mental health, because some of the patients are the same patients. And I guess an example of that, and to cut costs, for instance, if you have a diabetic that happens to be schizo, there's certain, I guess, standards of care that should be met, blood sugar, LDL for cholesterol. So how can we stop duplication on one side and the other? I guess the physical side, if the primary care physician are running these tests, how does the mental health side know that? And I guess that's my question. What is your vision of a truly integrated system that would definitely cut costs, but also would give us the kind of outcomes that we want from these patients, or should I say clients, who are both physical health and also mental health clients?
I think there are several mechanisms that we've already begun and that could be fleshed out further. And they include everything from building up and supporting much more strongly the idea of the medical home, so that the individual's care is actually coordinated regardless of whether or not it's a physical health or a mental health provider or professional. There should be one medical home for each individual receiving care. Second is when we actually do the work of the health care programs or health plans, is to use disease management effectively. And that means actually using disease management that focuses on the whole person and not on an individual disease state. Because the difficulties you're talking about where whatever the person is being prescribed for their behavioral health or mental health issue is not known or not recognized or not just integrated into what's being done on the physical health side, that is just a tragedy waiting to happen.
Exactly.
That is a medical error on its way. It's just a matter of time. They may have gotten a couple of near misses there, but it's about to hit. So we need for the individuals who are being the providers of care on both sides of the equation to be able to communicate, which is the third opportunity. And the third opportunity is to, I know I sound like a broken record, but actually have access to the information. And the easiest way to do that would be through secure for comprehensive electronic health records.
Right. And I want to mention, I know that the behavioral health coordination councils are great, but they can't solve this problem.
This is a huge problem
Right.
that has been present for, I don't know, decades, hundreds of years. But the whole idea is that we, again, have an opportunity to go forward with something where we can set what the priority is. And if the priority is not only prevention and wellness, but also integrated care across the different care categories.
And I guess that brings back, currently they are separated. So I guess what you're saying, will be the difference between the physical health and the mental health. They're currently separated.
We're talking about separate programs. But
exactly.
in the real world, in the community, they can actually integrate now. Whether there are two separate programs or two department heads, that's not where it's key. That helps us with our planning and strategy and all that kind of stuff. But actually in the patient room, in the patient's community, in their health, that's where it has to hit. And that can be done regardless of what department is managing what policy. The alliance is something that we can actually use to help at the state level with the policy development and the strategy. But we've got to actually be able to support the individuals who are actually on the ground providing the care to integrate.
Right. And I'm really this is one thing that I see as an opportunity that if we're going to have those outcomes that we want, we definitely have to bridge those gaps and start working across boundaries, physical, mental health, and not so much as in some of the silos that we see throughout state government sometimes.
I have someone who's sitting in the audience who hates it when I point her out. So her initials are Carla Denise Edwards. Mm-hmm. And one of the things that she said to me when we were having all the discussions about how things should be divided up, is she sinking under the seat right about now? Yeah, okay. Is talking about being careful in how we approach it, so that we don't try to separate the head from the body, because it doesn't work so good
and that's
to do that.
What I'm driving, that we don't need to separate the head from the body, and that here's an opportunity for us not to do that. Thank you.
Representative Gardner.
Thank you, Mr. Chairman. One of the things that worries me a lot as a resident of Fulton County, as we go through this transition, we look at the 09 budget, we see significant reduction in services for children's mental health, for other kinds of health services. And we in Fulton County know what happens when there are not services out there. People wait till they're really sick, and then they show up at the door of Grady Hospital. So I am worried about the impact of this transition on that very vulnerable hospital. And I guess I would like to mention one other thing while talking about mental health and physical health and how they can be treated together. It's one of the things that Grady does relatively well, because they have psychiatrists on the 13th floor and all kinds of other doctors on other floors. So they have an opportunity for people with medical issues who show up because of a mental health diagnosis to get the care they need. So as you go through this and watch the cutback in health services, we need to think about the implications not just for Grady's emergency room, but for the emergency rooms in the hospitals all over our state.
I think to speak to that in two ways. Grady is a perfect example of it doesn't matter who's in charge, and it doesn't matter where the money comes from, because what matters is, as Dr. Meadows said, what happens on the ground. We fund most of those mental health services, or many of those mental health services at Grady. We have mental health funding going there. On the ground, Grady is able to create an integrated system of care. That's doable all over the place if indeed you have the ground. If we think just what agencies are up here and department heads come and go up at the state level are going to make the biggest difference, we absolutely are not the ones. What we do is open up the access, try to keep the bureaucracy from choking the ground, and trying to move stuff as much as we can to the ground so that it has an opportunity to make the best of what we have to give it. The emergency rooms around the state, one of the biggest issues that has been consistently pointed out to me on the mental health side is one of the biggest ways we're going to cut back on some of the demand in emergency rooms to see people with mental illness is by moving more intensive, comprehensive, community-based services in place that are intended to keep people from showing up in crisis at the ER. That's what the ER is about, whether it's a physical crisis or a mental crisis, and it's no place else to go. Well, crisis stabilization programs, mobile crisis, which will go out to when the crisis is happening and intervene, ACT teams, which are teams of psychiatrists and social workers and nurses and peer specialists who can work together and case manage and go out and see people 3-4 times a week. Where they live, where they're actually living, is going to take a lot of pressure off of it. With the kind of resources we have, it won't remove it, but it's going to start turning the tide. It's like turning the tide, and that's what we need to do, turn the tide on some of this stuff.
So we do know what to do, but to what extent have we allocated resources for those wonderful programs that you've described?
Well, this year we had $11.2 million to put in resources, and in the past we had typically put the resources when we had new ones here and there. And you really can't get any critical mass like that. So this year we decided to put it in 2 intensive communities, Columbus and Savannah, to prove concept, to simply show that if you have money and if you put it in place, here's what it can do on these issues.
Could you share some of those numbers with us? I've heard you mention those two areas.
Yes,
a couple
we're
of times.
working on a document right now, I think, that's going to lay out for you, and we're going to be getting in to see you and also passing out to you a document about what's going on the ground.
About both Columbus and Savannah.
Columbus and Savannah.
Thank you very much. That would be interesting.
Representative Houston.
Could you tell me what areas those district Columbus and Savannah services? I represent Colquitt County, and I think we're about 4 hours from Savannah and pretty good ways from Columbus. Where do we go?
Well, at this point, when we're saying we're investing in Colquitt County, I can't tell you today where's the nearest crisis stabilization program, where's the nearest this. What I'm saying to you is that in order to do what we know is most effective, you have to do it in a concentrated way someplace to show that it can have impact. And we don't have enough dollars right now to put everything we need all over the state of Georgia. We don't have the dollars to do that. But by putting it here, we can start to show that if we can figure out how to make an investment strategy that puts these services in place, we can start to calculate for you and give you data about how those services are going to impact over the long haul on people showing up at the deepest ends. That's in jails, in prisons, in ERs, and getting totally alienated from their families and communities because they continue to go in and out of crisis and there's nothing there to catch them. It's not solving the problems for the state of Georgia. I'm not even purporting to say that. What it's doing is showing that if you put it in a concentrated area, you can begin to impact for that area and the people in that area what's going to happen when people go into crisis. Crisis isn't the only thing we need to invest in. We need to invest in front end as well. So it doesn't say that we've solved everything. We're just taking the resources we have and investing them in the most reasonable place. I know that I could come back to you and say, you're in Colquitt County, here's where your nexus of services, but these particular dollars we invested in a particular way.
All right.
Okay.
My next question, Dr. Meadows, I appreciate the job you're doing, and public health will be going over to your department. Is that not right? And you made a statement about how important you thought public health, it was like, I don't know if you used train wreck, it would be the next train wreck, it would be the next.
It would be the next tragedy if we don't fortify it now.
All right. Well, how do you feel about the public health took a big cut in the budget. Can you tell me the percentage of the public health funds took according to what other departments took?
About 12%.
What, it's 17 and 19%? When child support took a 2%, does it bother you that public health took a lot more cuts than the other?
Representative, I'll have to take Commissioner Walker outside and beat it to a pulp as soon as I find out
You
what
better
the real
take her, because
numbers are.
according to the figures she gave us, public health took a bigger cut, the percentage-wise.
I don't know the,
so maybe y'all better step outside.
Okay.
Thank you. Yeah.
And I think it's important to know, a lot of people are talking about child support, but child support cut some 60 to 70 people as part, early in the year. It did huge streamlining to bring its budget down. And so by the time it got to the point of taking cuts, I believe there's at least 34 positions that were cut in the final child support budget. Everybody across DHR took intensive cuts, but you got to separate the program cuts from the admin cuts.
Well, what you gave us, we were just looking at the percentage numbers. I think the percentage numbers came from your department, and that's what we had to look at.
Well,
I was real concerned, if we want to, we can talk about this later, about public health, but I do have some concerns. Thank you.
Okay.
We will be, again, members of the committee as well as anybody here who might be listening, we will be having a public hearing this coming Wednesday, February the 11th, from 1 to 4 in this room. I want to request, if you will, that you come prepared if you're going to participate in the public hearing to limit your remarks to no more than 5 minutes. I'm very well aware that that's difficult to do oftentimes when you feel very passionately about something, but we have 26 people today that have signed up to speak on Wednesday, and we're going to do our best to accommodate everybody, but in order to do that, we're going to have to limit it to 5 minutes. If you would like to bring material to be left behind for the members of the committee, certainly feel free to do so. I would like to thank everyone for being here today. I think we've made some headway in understanding what this proposal is, and we will continue with that job on Wednesday. We are adjourned. Thank you.